Yeah, good morning, everyone. The summer seems to have faded away quite quickly all of a sudden, doesn't it? And everyone's attention's turning back to this kind of work, I think, including my own. So this has been fairly a little bit last minute, so apologies for that, but we'll try and get some information in. And really, I think learn from each other how best we think we can manage our projects and our work together. Have had a number of roles, and as I say, I'm telling you really, or talking to you about how in a perfect world you can do things. I do not claim in any way that I've done things that we've done things perfectly, but we share what we've learned along the way. And my work's been mostly in Kenya, starting off as an anesthesiologist, anaesthetist, working on trauma projects, but moving quite quickly towards thinking much more about how to create sustainable change by embedding an understanding of how to make change. Okay, so the general structure this morning is a little different from what you were sent out, but basically we're going to look in three parts on approaches to projects and improvement, because we're all involved in this work to try and improve something, aren't we? And we'll discuss a little bit about why they're needed, and then we can have some discussions between us to really look a bit more deeply at whether we're quite sure that the projects that we're running are well designed in order to solve the problems that we perceive. We can discuss any improvement methods people are currently using within your health partnership activities, and take a look at whether actually the projects are just projects, or are they trying to address the broader issues that you need for change, such as culture and leadership. And that will be part one. In the second part, I'm going to go into a little bit more detail about the improvement journey and how we can follow a process in order to try and achieve the outcomes that we desire. And thirdly, we'll have a bit of presentation about making and sustaining change, and a bit of discussion about the place of leadership, followed by discussion again. So that's the general setup for the morning. Is that okay with everybody? Is there any, if there are any other things that people want to discuss along the way, just chip in. There's not very many of us, and we can divert a little if you'd like to. So we're all involved in improvement approaches in health partnerships. We're all doing something quite different. Our projects are different. Perhaps our ambitions for our health partnerships are rather different. And actually, how do we run our health partnerships? And is there any discipline around that? We know generally what we want to do, but very often we haven't really thought about how to get the outcomes we desire. We tend to be clinicians or people in other work, but we're not project managers. We don't necessarily think in that way about exactly how are we going to get these outcomes, and are we absolutely sure that our outcomes are the right things? Are the projects we've come up with really designed to address the problems we're trying to mitigate or solve? Do we have an overall plan for the health partnership? How do we run our projects? How do we manage them? Do we manage them, or do we just let them run along? So project management is a big thing in the big wide world, and it has a purpose, of course, of tracking and maintaining progress towards a goal. And this is any type of project in any type of business. That's designed to make sure you get good use out of time and money, and to reduce rework, to get better decision making and communications. But projects on the whole of this sort have a very clear outcome. You're going to build a new building and make it work, or you're going to launch a new product onto the market. For us, very often, an improvement strategy is really more flexible for us to use, because we're working in quite difficult circumstances where you can't predetermine outcomes of a project very easily. You may start at point A, but you don't really know quite where you're going to end up sometimes when you're doing the kind of work that we're doing in health. But people use different methods, and there are very many project management methodologies described to choose from. Clearly, we're not going to know even one of those well in our world, probably. But the basics of a project are really worth thinking about before we embark on it, and deciding whether or not we've identified properly the baselines for our project. Do we know its scope, its schedule, its cost? The very basic things, aren't they? And are there other project dependencies that we need to think about outside the project? What needs to happen before some other thing can happen? So do we need a building before you can put your library in it? Or do you need to appoint a particular person to a particular job before you can improve care in HIV? Whatever it is, what are the other dependencies? So that will help to plan timelines and identify things that might block our project, and help us to try and avoid unnecessary delays. And we very much need to know who the project stakeholders are, to communicate with them and to understand from them what their interest is in the project. And then break down project milestones into manageable chunks, each with a defined goal. And along the way, one has to keep teams motivated and communicate progress and successes. And we're often really, and this is something I think we don't always do particularly well, which is really define who's responsible for what in the conduct of a project. So this is basic project management stuff, which I've just picked off the internet. Some people use charts. Some grant applications demand that you have charts, tracking your work and showing where it's going to happen across time. And you can supplement that with who's going to lead on those projects and what the outcomes at each stage of completion they will be. That's a Gantt chart. We won't spend any more time on that. But do these approaches really fit our projects? I think global health projects don't always fit this rigid approach. We may not have had much chance for scoping our project. The variables are often not well understood at the outset, and solutions are far from clear. And there's limited time for co-working and project setup. And we're all rather loose teams and usually volunteers, with all the site difficulties that brings. We can't demand people to be present for meetings or team development. But health partnerships are an excellent starting point for running projects, because there's usually a relationship and trust that started to build up. And trust is an incredibly important thing, I think, as a starting point for making change. If you had to put in a grant application, many of us will have gone grey or lost hair over trying to do theory of change templates, which try to bring together from on the right-hand side, what is it that you're trying to achieve? What's the mission statement? Why does your partnership exist? What impact are you trying to have? And then try to build projects which work towards those, which are consistent with those aims. And design the things that you're going to do, the activities, in order to achieve the outputs and then the outcomes that you want from the projects. They're very painful to do, and I'm not going to talk about them more because I come over in a cold sweat every time I look at that, from having done them before. But one of our big issues really is, do we deeply understand the problem we're trying to solve? And deeply is a really meaningful word here, I think, and we'll come back to it. And if we're going to get to deep understanding, how will we get there in order to try and put in the right solution? Because it's very easy to put in the wrong solutions for the problems. So, for example, in Kisumu County a couple of years ago, I was there, and they were having a meeting to discuss the 30 mothers that had died in the last month in childbirth. And the sort of conclusion very often from data like that was just horrific. And the normal outcome would be that there's a cry for more obstetric training. We need more. All these mothers are dying. This is terrible. But I attended a whole day mortality and morbidity meeting. And of course, it was much more complicated than that. And predominantly, there were system failures leading to these deaths. Many of the pregnancies were unknown because they hadn't been picked up in the community. They'd had minimal or no antenatal care. There were very late referrals when there were problems from the community to the local dispensary, and then late referrals from the dispensary to the hospital. Complete failure to recognise that the patient was sick and deteriorating and to act appropriately on it. And a lot of that was due to communication failures and lack of leadership skills. And unless obstetric training contained a lot of other elements around system improvement, that data is never going to shift those outcomes. Another very sad episode that I can relate is neonatal deaths were high in one hospital, and one had just occurred. And we had a very distressed young doctor. This is Dr. Shwetha, who was a medical intern in her first job, a Kenyan graduate. And she had gone to resuscitate a fit, healthy baby. Well, he was just a bit flat at birth. He was a normal full-term baby, the sort of baby that just needs a little bit of suction, a little bit of oxygen and a bag and mask, and they're away and they're fine. And she took the baby to the resuscitation place in the maternity unit, and there was no bag and mask, and there was no suction, and there was no oxygen. And she ended up running around the hospital with the baby in her arms, trying to the accident department to try and find resuscitation equipment, and the baby died in her arms. And it was a tragic story, tragic for the mother, tragic for the baby, tragic for her. And so do we need more neonatal training? This was a pure system failure. Clinical education was not required. She was a very bright young woman. She knew exactly what to do, but training in improvement science and leadership really was needed in order to try to improve this terrible situation. And so many of these stories lie behind the data that we see. And unless we really deeply understand them, we can't solve them. This is her trying to, at the start of trying to solve these problems. We'll come back to that later. Now, this has been recognized at international level as well. And there were 3 very big papers on quality services that were published in 2018 on how to achieve good outcomes, good health outcomes, looking at health systems across the world. And it was the Lancet, the Institute of Medicine, Engineering and Science in the States, and the WHO and OECD with this one, delivering quality health services, a global imperative for universal health coverage. And they all identified that lots of money and lots of projects were being run that were not shifting the dots in the data. So a lot there's definitely been a great decrease in child poverty and in world poverty, which is sadly going to have been rather challenged by COVID, and we will have slipped back. But there are some very intractable problems, and maternal outcomes, pregnancy outcomes are one of them, in fact. So they recognise that there's this need for the drive for quality, and that the size of the problem is that probably at least 8 million avoidable deaths are happening every year, despite massive investment, particularly in clinical education, and that we're missing the system problems all the time. And so although this is understood at that how level, how do we approach these deep-rooted issues at grassroots level? How do we really get to understand our issues, produce consistent, reliable outcomes, and enable us to continuously improve? How do we get there? Who's done that? Well, one of the outstanding businesses that have done this over the years, that health suddenly started to take a bit of notice of 25, 30 years ago, was this company, Toyota, building cars in Japan, who really had become the most successful company in the world about 20 years ago. And they had done this through really getting to understand their issues. They were able to produce consistent, reliable outcomes and continuously improve. And of course, that picture is a little bit different now. And it's, or a lot of the car industry is robotically delivered now. So what have we got to learn from industry? Well, Toyota did it in 3 ways. They have a process called 5S, which is organization of the workplace, of the people and the equipment, being tidy, having things in the right place, and things in the place which means they're least effort for us to find them and to use them and to just have an orderly, well-structured workplace. And then continuous quality improvement methods, or Kaizen as they call it, improvement and innovation, a system where you continuously look at what you're doing and improve it and really understand what your problems are. And then they have a total quality management system, a company-wide system for managing quality. And all of these things are really relevant in health. And they started to be translated for health environments by the Institute for Healthcare Improvement in the United States in the 1990s, which is when really improvement science in health was born. And the Institute of Medicine in the States produced this document, Crossing the Quality Chasm, which really made people wake up to patient safety and quality. How do we reduce errors and how do we improve quality? So many more things in common than one might imagine with the car industry. And they continue to do it in industry. They have to produce reliable products within a cost envelope all of the time. And so then for the first time, really, quality in health was defined. And given these dimensions. And I wonder sometimes if we pay attention to all of these dimensions in our projects, we should be trying to produce work that's safe, effective, patient-centered, timely, efficient, equitable, and more recent, those 6 dimensions have persisted since the 1990s, and more recently, integrated has been added to that list. In other words, all the care we give and all the things we should do should be part of a continuum and integrate with other services or other parts of the service. And the IHI developed what they call their model for improvement. This is it. And it's very basically, it's a model which encourage us to always be looking at what are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in the improvements that we seek? Because they don't always. So those are are we clear about the aims? Do we know what we're going to measure? Do we have ideas about how we can make those improvements? And do we know how to test ideas before implementing changes? And they adopted the well-known PDSA cycle, Plan, Do, Study, Act, where you make continuous small tests of change and see if they work before you implement at larger scale. So Toyota had their methods, and then the IHI have come up with their own model for improvement. And there's something to learn from both of these. And there are also many other methods that can be used as well. So if we're going to improve, what use sort of these kinds of approaches, what do we really mean by quality improvement? Because everyone talks about having quality improvement projects nowadays, but actually it's, have we got a systematic approach to achieving better outcomes? And successful projects we could substitute for that. Because without a systematic approach, I think we're unlikely to be very successful. And very often, and I know to my cost for having tried to achieve outcomes without having a good systematic approach, how easy it is to fail without one. The IHI also created this framework for safe, reliable and effective care, and showed, and I think this applies just as well, not just for care, but for some of your projects, which are about libraries, or implementing any projects, is have we got the culture in place and the learning systems in place to enable the change to happen, to enable this project to happen? Have we got all of these elements? Have we got good teams, good communication? Have we got transparency? Have we got good leadership? So I think this is quite a helpful model to just check out. Have we attended to all of these elements? So these structured approaches, as I said, there are many. In industry, the Toyota method is often called lean. There are many others related approaches. Six Sigma is another one, which is very reliant on data, which is also incredibly important. And there are mixtures, and there are many others. A lot of them came from Japan, but also based on earlier work in the United States in the car industry, and Ford, in particular, the Ford car model, which the Japanese took and really honed down. And in the design world, what we might call design thinking, they all have a process to go through to reach their outcomes. So which to use? Well, there's not much evidence of any being better than the other. And an awful lot is about people owning their actions, attitudes, and behaviors. So how do we tend to those in our projects? We focus a lot on actions, but don't always think about how are we going to get the right attitudes and behaviours that will help our projects to succeed. So at that point, I'll stop for a bit, and maybe we can have a bit of discussion and think about, if you think about your projects, are your projects truly matching the problems you're trying to solve? I presume within your partnerships you have some projects running, or you have things you want to achieve. Are they really structured to match the problems? Do you have that really deep understanding of what's creating the problem? Do you use project plans, improvement processes? It would be very interesting to learn from you what you do use. And do you address culture and leadership at all? And do you think about your work across all the quality dimensions? Maybe we could have a bit of a chat about that for a little while, Alice.
So we've got 5 minutes before we were going to sort of move on to part 2, actually probably a bit more than that, 7 or 8 minutes. So there's time for, obviously, Kerri, you joined one group, I joined the others. And first of all, all we can say is thank you for your skills and expertise. That was very definitely a theme of how much everybody's even got from this first section of listening to you. So thank you very much. So any questions or comments for us to share with Kerri between the groups?
Well, I would just say we've had a very interesting session, which I'm learning a lot from, and there are some fantastic projects being run in different ways and quite diverse projects. So we were just beginning to explore, but there's some really good thought going into how to run projects in some of the projects, and in others that people are involved in just part of projects, so don't have as clear an overview as the total project. So some of them are quite big, but very interesting thoughts. And we were just getting on to thinking about how we frame the problems. But thanks everybody, that was really interesting, and we didn't really even with all that time, we didn't really start to hear enough from everybody, but some really good stuff going on. What about your group? I don't know, would somebody else like to add to that from our group? I'm sorry, I ejected myself early by mistake. So I missed the last minute. I pressed the wrong button.
I think in our group, more of us were sort of at a beginning stage of a project. So, but, much appreciated the various structures that you offered us, to sort of, and I was thinking myself that we need to dig a bit deeper, and I was reflecting a bit on the challenges of doing that across a screen rather than being able to meet physically and spend time in a place with people, and it is a huge challenge for all the partnerships at the moment.
I agree, but it's suggest it's a step that's worth investing in right at the beginning to gain that understanding and buy-in before the start of whatever you're trying to do. And it sort of is, we don't know really how achievable it is to build that sort of consensus and will across Zoom, but we certainly can't miss it out. Yeah. I think.
I'm suddenly thinking, because this is what we talked about a bit just now. I have a similar issue, and it's a different way, but when we've done our training on the ground, and then part of the program is the idea that cases are uploaded for external mentoring. That there's an external remote mentoring element to this, and it keeps falling down. And whenever I've done remote mentoring interventions, they keep falling down. And I don't know if that's anything that any of you use in your programs. So we've had quite a lot of conversation around that. And one of the ideas we're talking about is just to structure it better in, like, say, on this particular day in your diary, everybody gets to, you plan it into your program as if it was a day that you were doing there, rather than let's fit it in when it suits everybody. Because if you fit it in when it suits everybody, it never suits and it never happens.
I think that's true even when we're not remote, actually, isn't it? And I mean, the IHI talk about this quite a bit, and they do this as well in the car industry. I went to one of the factories in Oxford just to see how they do this, but it's short, sharp meetings, isn't it? And having a real focus for keeping things on track. And the huddle concept that the IHI talk about in terms of keeping momentum in projects, which is 3 questions, short meeting, no chairs, just meet in the corner. What did we say since we last met? What did we say we'd do? Did we do it? And what are we going to do next? And trying to keep really focused on the outcomes with frequent but not long meetings. Try to capture everybody quickly and spot whether people have done what they said they were going to do, and if not, why not, and what's holding things up, and then move on. So I don't know whether that's a very realistic thing to do across Zoom. I mean, I have regular meetings with the project I'm running remotely in Kenya at the moment, but not as frequent. We are actually having longer meetings less frequently, but I think we might have been better to have those short, sharp meetings more frequently.
That's really helpful. I didn't actually know. See, I didn't know that this was a thing, as it were, which is great, which is why I'm here. So from our partner's side, is that a concept that you feel would that be workable? I mean, my partners are obviously not on the call here, but
ask them, I would say, and see, so what kind of communication would work well for them. But people committing a lot of time in busy days. I mean, I think often there's not so many fruitful outputs from long meetings.
Right, let's move on then.
Okay, so now we're going to look a little bit more detail at the improvement journey, in case this is helpful to some of you in the start of your projects, and even to reflect on projects that are already underway as to where we are in the journey and how we're going to maintain progress. So people talk about quality improvement, and it has many definitions. It's what we're all trying to do. But quite simply, it's just a systematic approach to achieving better experience and outcomes. And that might be implementing a library, it might be improving diagnostics, it might be better bedside care, it might be improving flow in a hospital, it could be anything, but applying a systematic approach. These are difficult things to achieve, and it does require a systematic approach. I think we've understood that from our learning from industry, and it is a bit of a frustration to me that people call many projects quality improvement projects, and yet there's no evidence at all of the use of a systematic approach. So without that systematic approach, I would contend that things are not really quality improvement projects. You need to be able to demonstrate that you're following some sort of a systematic approach to your improvement. Now, one approach is this. Toyota implemented something called the A3 worksheet, of which this is one version, and we have modified it a bit in our work. We run a course in quality improvement and leadership training for healthcare workers, and the idea of it's A3 because of the size of paper, which is double A4 size, and their idea was that everything should be on a page, that everyone could see what the project is and what the steps are, and be able to share their common approach. And often through huddles, through these little getting together of meetings, saying, where are we with this? What are we doing with that? And so on. So a plan on a page approach of seeing your whole project and the steps in it. And we have found this very helpful. So I'm going to just share it with you, because it describes the steps in quite an understandable way for those of us that are not experts in this work. And you can see that it contains a project title and who's the lead and who's the executive sponsor, who said, yes, let's do this, because they're the person that you might wish to go to. And you update these sheets, of course. So starting right at the beginning is the problem that you're trying to solve, which might be a lack of poor patient outcomes because of a lack of knowledge of certain elements of care, or it might be that patients arrive, women are dying when they come from childbirth. That is the problem that you're trying to solve. Very often people put solutions into a problem, but you have to strip right back and say what, and then you can keep checking all the time that your actions are actually relating into that problem. Remember that the template for the theory of change, it had keep the problem in mind and make sure that all your actions actually relate to that problem. And then these various steps along the way, and understanding the background to the problem is really, really important. And who are the stakeholders? Who are the people that this problem affects? It's worth making a stakeholder map and knowing who they are, who you need to get in touch with, and never forgetting the patient as being the major stakeholder, because that's what we're all about, aren't we, really, is we're all about patients, and they should be right at the top of the list. And you may have a representative stakeholder who you meet with, a representative patient who you meet with as one of the stakeholders. And then, having identified why the problem exists and where it exists and what it is and who it affects, then you can progress to looking at what the current state is. What are things like now? What's our baseline? What have we got? And what data can we find about it? We have only 10 books and no library. We have a completely disorganized physiotherapy department. We have radiology, diagnostics available, but very few tests being performed, and so on and so forth. So you can find some sort of data about any problem. Disorganization could be represented in photographs. The lack of availability could be represented by an interview with the patient, a recorded interview with the patient, and so on and so forth. So some sort of baseline that describes what things are like now, and thinking about how you would measure that. How would you measure the current state? So thinking about data right from the beginning, because unless you collect data, a baseline data, and then data later on, you will not know whether the intervention you've put in place has created an improvement or not when you measure later on. And as we know, we often initially put in solutions that are not right, and we need to change. So having seen what the current state is, we can then progress to a root cause analysis, and I'll go through that in a little bit more detail in a moment. So when we've really understood things, then we can make our goal and make it a smart one, specific, measurable, achievable, realistic and time-bound, which will help us to keep our project on track. And at that point, when we've got a vision now, what really do we want things to be like? And it's a very useful thing to do to articulate that future state. What do we want it to be like? We want patients and staff to be able to access a library so that everybody learns more about health. Or whatever, these are just coming from the top of my head. But what's that vision? And then move on to thinking, well, how are we going to get from there, current state, to the future state? What interventions could we put in place? And this is where the PDSA cycles become very appropriate. Small tests of change towards trying to make the improvement, but not forgetting, with small tests of change, you could also envisage a future state which is really very different. You might call it more innovation than improvement. You might say, we're not going to have books, it's all going to be virtual. You might say, we're not going to make people come to us for their radiological investigations. We're going to have mobile equipment and go to them, or some, a completely different model of delivering the care. So it's worth thinking very radically at this stage. But all the solutions don't have to be radical. They can be just improvements. But just think about what, be carefully about not just making small improvements. The saying from Henry Ford was that if you'd asked people what they wanted in terms of improving transport in the early 1900s, they'd have said a faster horse rather than a car. So he had the vision to make cars widely available rather than to improve the number of horses available to people to get about. So you might call that an innovation rather than an improvement. So it's worth having those thoughts. And how are we going to review your progress? When you're putting your interventions in place, your PDSA cycles, how are you going to review that? And that's where we talked about the huddles. What did we say we'd do? What happened? What we're going to do next? And what measures have we put in place? And are we measuring them each week? And finally, there will be roadblocks and challenges. What are they and how are we dealing with them? So this is the core improvement process. I've just been through it now with you. I won't go through it again, but I went through it on the chart. So that core improvement process comes through in any improvement methodology or design thinking. And the problem is the really big one. Einstein has been credited with so many sayings, but this is one of them. which possibly really did come from him. If I had an hour to solve a problem and my life depended on the solution, I'd spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. And we so often set ourselves off on the wrong track. I think that's so true. So we need to think deeply about problems, but always from the patient's perspective. That's what we're there to do. They're here to improve human health, individual people's care, and really understand the background to it, and try and avoid creating problem statements that contain solutions. We talked about the stakeholder map. Don't forget anybody, and the current state. And I've been so impressed by this tool, using it, is to really understand this current state, is to undertake a Gemba walk. The Japanese call it. Go see, ask why, but always show respect. And it means going to the real place, going to the workplace, the place where this problem exists, the place where people doing the real work are working. So if you want to improve a laboratory, you must go to the laboratory and talk to people who are there. Unless you do that, you will not arrive at solutions that are really useful. So the Gemba walk is so interesting. And people who've worked in a place for years go and do this, and they come back with their eyes opened and they say, we had no idea such and such a thing was happening. We had no idea we didn't have this. We had no idea we did have the other. And it's absolute eye-opener for everybody. And it's important to get people to really see the problem in reality in the place where it manifests, the Gemba walk. And another way of looking at the current state is to do process mapping and spaghetti diagrams. Just follow people, see what they do in their work. How accessible is the library? Are we going to put a library full of books somewhere where it will take them so long to get there that they won't go? Or has it got to be locked and you can never get the key because things disappearing? So what in reality does the system really look like? And draw it, follow people, time their movements, time what they have to do. And only then will you realize where things are failing. How can a community health volunteer visit 200 widely spread families in a community every month, as well as doing a full-time job? It's not realistic. So you can't keep asking them to do more and more. And also the Japanese are very keen on looking at wastes, what we're wasting in terms of time, resources, manpower, and there's a whole list of wastes. I've got a slide in a moment. And do we know, through the process mapping, we'll hopefully start to understand flow better. Where are the cues? Where are the constraints? Where are the bottlenecks? Where are the problems that will get in the way? It's the most powerful improvement tool, process mapping, really. And by drawing it, it makes the system visible to all stakeholders, often for the first time. And it also records what people are doing at any one time in any one place. So you might have a ward here and you're trying to track how people work and where the resources are kept, and so someone's tracked there, a doctor moving around and a nurse moving around, and so we start to understand the patterns of movement. And if you remember, I showed you earlier on that very tragic tale of the baby that died. And Dr. Schwether here, and this is the first day into the course. They had done this piece of work to try and understand how the movements of everybody and where resuscitation equipment needed to be and how you were going to make sure it was going to become available. So it's a very powerful tool. Everybody can see the chaos of our daily work. And while we're looking at the current state, we can look at the wastes that are occurring all the time and that consume time, effort, and money, and they're in all of these. The downtime is the mnemonic here. And we don't have time to go into that, but it's a very useful tool, because this is time and money down the drain. And if we don't address waste in any system we're trying to improve, then we will continue to pour time and money down the drain. So lots of ways of when we've done all these tools looking at the current state, we need to now analyze it in a more structured way. Why the problem exists, and the root cause will be the real cause of the problem, and it's not always the most obvious, and there's lots of tools that can help in a root cause analysis. There are 3 that we use particularly commonly: the 5 whys, the fishbone diagram, and the Pareto chart. And I think a lot of you will be familiar with this. Is when you've defined your problem, is asking why is that? And then asking that question about 5 times, not always 5 times, it might be slightly less or slightly more, but when you can't answer the question any further, that is the area to put your attention. And apologies for the rather anesthetic analogy, but a good one is the surgeon is in theatre and his patients are late, constantly late arriving, and he's sitting waiting and getting agitated, and so is the anaesthetist. And very often the tendency might be to define the problem by saying, we don't have enough porters in this hospital to bring the patients to theatre on time. Now that is a very poor problem statement. The problem ought to be patients are not arriving in time for their surgery to take place in a timely manner. He had put a solution into, or she had put a solution into their problems. We don't have enough porters. Well, if you really look at this, why is the patient arriving late in theatre? Ignore that solution. Well, the porter is delayed. The porter arrives very late. So why is the porter very late? Well, when you really look into that, you find that the porter couldn't find a trolley that was working. So why was that? Well, because the trolleys were broken and no one had arranged to have them fixed. So why was that? Well, there's no structure in place to routinely maintain equipment. So you move from the first thought, which is that we need more people, through to realizing that actually you need a maintenance contract with somebody or a maintenance system for a piece of equipment, which shows how a bit simplistic, but I think it shows how powerfully you can move from thinking your solution is the correct one to it being an entirely different problem, really. I don't know if that's helpful. And then the Pareto principle, which Pareto was an Italian statistician, I think, if I remember rightly, in the 19th century, I think, and who identified that things aren't distributed evenly in life. And it's a very, very true observation. The 80-20 rule often applies, though. And he based it on the fact that 80% of Italy's wealth belonged to only 20% of the population. And for many events, about 80% of the effects come from 20% of the causes. So you may have a long list of causes of a problem, but it helps us to analyze which causes to work on, because most of the effect will come from addressing 1/5 of the causes of a problem. So identifying which those key causes are is really important, because we can probably forget 4 out of 5 causes and just focus on 1 in 5 of the causes and get an 80% improvement. Another way of looking at problems is the fishbone. So here we have, because it looks like a fish bone, so we have our problem here, and there are all kinds of things that will contribute to our problem. And there are, again, lots of models of fishbone, lots of different boxes. This one is all M's, but you can find your causes here and say, is it a problem of people, of methods, materials? Have we got the resources? Is this something to do with the environment, measurement machines? What is it causing? And you can categorize the causes that you think are all of the things that you think are leading to the problem, and have a nice visual representation of, and then you can see sometimes where a lot of the causes are lying in one area more than others. This is a real one. This is done in a different way: documentation, environment, process, people. So this is length of stay on a ward is 2 days longer than we'd like it to be. And why is that the case? People have just used Ishikawa drawing. And all the time thinking about the data that will tell us something about the problem. What can you collect that will tell us about the problem in order to then create this SMART goal? And we all ought to have a goal, oughtn't we? We all ought to have a SMART goal in everything we're doing. And are we sure that it is SMART? Is it specific enough? Can you measure it? Is it achievable and relevant? And have we set ourselves some time boundaries by which we would hope to have achieved this change? So that's one way of looking at problems. It's a way we use with people, and we find it fits problems big and small. And so I thought now you might like, perhaps in your own groups of people who are working together with their problems, might like to give some thought to the first half of the A3 worksheet, and work through it and try and think through what they know about their problems and whether they have these steps in place. Do you know your problem? Do you know? Have you made a map of your stakeholders? Have you described the current state of your problem by looking deeply into it? And have you analysed it? And have you got a SMART goal? You might like to just take time in your own groups to think about those things for a little while. Is that all right, Alice? Okay, so making and sustaining change, because this is a lot of work and a lot of effort, isn't it? And an awful lot of projects 5 years later are invisible in terms of, can you even see them anymore? And sadly, so we've worked through the A3 worksheet as far as creating a SMART goal, and we haven't got time to concentrate very much on the rest, but we need to finish the process of making and sustaining change. We need to envisage the future. That was future thinking, future state, including trying to think innovatively, designing and testing those small tests of change, the PDCA cycles, measure, data. And then there will be barriers, roadblocks, and challenges along the way. And something when we were talking, which I haven't included here actually, that Jane Rose pointed out, is that projects should also have a risk register, really. You should identify the risks in terms of successful completion of your project. So thanks very much for that. And I didn't put that in, but it's part of being able to anticipate problems and the barriers and challenges is to have a risk register and to know whether the things that if something happened that your project would completely fall over, and just being aware and putting in as many mitigating things to stop project failure as you can. So we need to finish the process and keep working through, and it's not a one-off work through an A3 worksheet and you're done. You need really repeated use of the PDSA cycles testing and refining these ideas, accumulating information, data and knowledge, and then gradually implementing new procedures and systems to sustain change. Lots and lots of PDSA cycles. And it's not even just one ladder, really, because you'll find that you start looking in an area which affects nurses, and then it leads you to another whole process which affects porters or receptionists or something else. So you will find other things always to keep addressing, and it won't stay the same. So we haven't yet talked about leadership, or only very, very briefly, but it really is a key, absolutely key sustainable strategy. And again, a bit like quality, there are so many definitions and so many people think something slightly different, but you can think of it as how to work with and through others to achieve improvements in our scenario in terms of services for people's health and healthcare. We ought to put well-being in there as well, isn't it? Because we ought not to be just fixing people's health, but stopping them get sick in the first place. So you can always improve these definitions. But leadership is certainly key, because without people having skills in leadership, change isn't going to happen. So it's a natural companion to QI. And why is that? Well, it's been recognized for a very long time. One of the gurus of management in the States, Joseph Duran, wrote it all the way back in 70 years ago in the Quality Handbook. Every individual in the workplace needs to take responsibility for QI. And if staff aren't empowered to do so, results will be limited. So apart from having a structure for your QI projects, you really need the people to be on board. And this is a much softer set of skills, if you like. So people, to be empowered, need to know how to manage change themselves. The people in the place where you want change to happen, how to build teams, because you can only solve problems through teams. How you can create a culture for improvement, which will sustain and go on and carry on having people enthusiastic to keep change, because you'll never reach the end of this process. People who know how to influence others, and leaders, and not just leaders, but everybody in the workplace should understand how to show compassion. And if they're able to do that, then it's a fantastic way to build will for change. In the course that we run, the very first course, we were actually so very lucky to have a great team of people to test our ideas out on. And Dr. Kilonzo here is the pediatrician, and he was the medical superintendent of the hospital. And we were so lucky because he engaged so well and so willingly right from the beginning, because to a lot of the people in the room, they were from different cadres. He was a bit of a god in a way. It was very, as hierarchy's been mentioned before, but he was very willing to get down there on the floor, doing the spaghetti game, which is a well-known game for building teams and for getting people engaged at the same level in something as an icebreaker. And he was very willing to do that. And I can't emphasize how important that is, to engage with senior leaders. But leadership isn't just for the bosses, it's for everybody. And we've tried this out with lots of participants, a couple of dozen at a time, learning skills through doing QI projects, but blending leadership into the work, so that they're learning about their colleagues and how to effect change. I'd just like to just show you a little clip, I think, of this wonderful lady. It's who's one of the first attendees of our course, to show just how far you can go with people. And I'll just play you a little bit.
So my name is Karoki. My other name is Grace. I work in Laikipia County. I'm a pediatric nurse in charge of the pediatric unit. And when I came to Nanyuki, I was trained on the Springboard program. Springboard program helps us identify the major gaps and the projects to improve them, and also to sharpen our leadership skills. So I realized in the pediatric unit, the dose volumes or the calculated doses were too small, and it was difficult for the nurses to get the correct dose volume. So with the formula that maybe later I will share, I started to implement it. And the simple formula was to get the correct dose volumes so that the children get the right doses that are not toxic to their kidneys or the liver. So the project was to calculate the dose volumes. I provided a very simple formula that could help us calculate the dose volumes, a calculator, and I also developed as a column on the original T-sheet or treatment sheet that could be able to capture all the dose volumes calculated, so that the next.
Okay, we'll leave it there, but Kuroki is a wonderful woman who just was dying, had so many ideas and was just dying for some structure, but she is very much a natural leader. But here she is in a small hospital in the middle of Kenya, learning and getting really enthused because she feels empowered. And here she is in London at the 3,000 delegate International Conference on Quality and Safety in Healthcare, a year or two later, with her poster, which got a commendation. And she has gone on, not always strictly using the methodology that we taught, but just so enthusiastic to carry on improving all kinds of things, and she's done many other things. So I think the transformation process of some leaders, of some individuals, can be very transformative. Now she was in charge of the ward, but she otherwise wasn't that senior. So when I talk about leadership, I mean it's for everybody. I mean it's for frontline staff as well as just leaders.
So my name is.
We built a curriculum which relates to QI projects, and these topics are very classical leadership topics, but we try to intersperse them and show why they're relevant. So looking at personalities at work and understanding your colleagues and why it's helpful to have different people of different type and why people react as they do. How to be effective, how to understand your circles of influence and concern so you direct your efforts at the right places, how you listen. Emotional intelligence has been tremendously popular. Delegation, motivation, conflict management, and so on. So the list is all there, but we do intersperse the teaching of this, and I think it's really important. We've just been working with a very good organization in Kenya who are very good at delivering QI, and they had identified actually that they didn't have a leadership curriculum and are now successfully delivering our curriculum alongside their QI work and finding it's very helpful. So empowerment means enjoyment at work as well, and it really is. It really is great to see people who felt they faced problems that they just didn't know how to tackle, suddenly finding that they're able to do so. So what else is needed really for this sustainability? Well, you need an ongoing structure to support improvement within the organizations you're working with, which means the engagement of the most senior leaders. And playing back to the Toyota method of 5S, continuous quality improvement, and then total quality management system, it's there within that. It means your organization must value this journey to continuous improvement, but that in itself needs some structure. It needs someone to champion quality at a senior level. It needs people who, the buy-in of senior leaders to make things work and to sometimes provide, sometimes even a small resource to make something happen, someone to go to if projects get stuck who can unstick them. And also then you need to build people within the sites that you're working with, within your partnership projects, within your own organization, improvement coaches who know a little bit about, who've run a quality improvement project before, who can support new ones. And so you sort of start to build a capability for people within the organization supporting each other. And if a project is small in one part of an organization, can it then be spread to another with the help perhaps of coaches? And then you need ultimately to have more people to teach and learn about quality improvement methods. So we need to develop skills for people to do this kind of teaching. Just some of the projects that we've done, and we're all in partnerships, and I think we can really understand the value of partnerships and how working together we can help each other and all learn how to improve what we do. These are just some of the people that we've worked with in the past. So that's all I have to say. And I don't know now if you'd like to have a bit of a discussion about sustainability now, again in your own groups, and how you can maybe build that in, and consider also how you're addressing leadership at every level, and whether there's something you might be able to perhaps add in to help that sustainability.
Yeah, that sounds great. Thank you so much, Kerri. Any thoughts, comments, questions?
Yes, I was very happy to be told just now that common sense goes a long way.
It's reassuring, isn't it? Because otherwise it's like, oh, yeah. Yeah. I was saying I was feeling slightly overwhelmed, but it's true. Common sense goes a long way. It's about how you put the common sense onto paper in some sensible way. Yeah. Thank you for that, Kerri. David.
Yeah, I suppose I shared with our small group that during Kerri's last presentation, I had a sort of small light bulb switch on, because I had been thinking in terms of our wider project that the QI, we'll do it in this project, and then we'll maybe introduce it into this new sort of partnership. And then I realized actually QI needs to be everywhere in whatever we do, and our trustees, we have an AGM in a week's time, and they're going to get encouraged to sort of use this sort of approach throughout what we do, because I think it's so applicable to running a charity as well as to running a partnership. So thank you for that.
I also thought that QI in any set of organization, especially in the healthcare setting, should be made a business as usual for everyone, and all leaders should empower their staff so that it's made like a mandatory, because we all work in this environment where we think that, oh, that's nothing to do with me. No, it's everyone's responsibility. Yes, so in terms of leadership and sustainability, I think we all leaders in our own entity, so we should make QI as a business as usual, if possible.
It's been a fantastic morning, Kerri. Thank you very much.